Hello everyone, and welcome to the 6th webinar of series of webinars hosted by Faculty of Dental Sciences, University of Peradeniya, Sri Lanka. I'm Udari Abeyasinghe, and the co-host tonight will be Dr. Sumudu Medawela. Now, the ones who joined us with the last webinar already know who the guest speaker is. However, it is my duty to introduce her today as well. She is an eminent oral pathologist in Sri Lanka. She is none other than Professor Primali Jayasooriya. Professor Primali Jayasooriya is currently attached to the Department of Oral Pathology, Faculty of Dental Sciences, University of Peradeniya. Her academic career spans for more than 2.5 decades. She is a graduate of Faculty of Dental Sciences, University of Peradeniya. She earned her first postgraduate qualification, PhD, from Tokyo Medical and Dental University, Japan. Later, she extended her academic aura with MD in oral pathology from University of Colombo, Sri Lanka. She currently works in the capacity of head of the department and professor in oral pathology. She made her valuable contribution to numerous academic forums nationally and internationally and received multiple awards, including multiple presidential awards and National Research Council Merit Award for scientific publications. Her research interest is on molecular pathogenesis of oral squamous cell carcinoma and odontogenic tumors. Also, she has co-authored more than 50 international full paper publications. With that introduction, let me invite Professor Primali Jayasooriya to deliver her lecture. She will be talking to us on significance and challenges using oral epithelial dysplasia in the management of OPMD and oral cancer. Over to you, madam.
Good evening, everyone. Thank you, Udari, for that kind introduction. Today's topic is significance. Today's topic is significance and challenges of using oral epithelial dysplasia in the management of oral potentially malignant disorders and oral cancer. 2017 WHO classification defined oral potentially malignant disorders as clinical presentations that carry a risk of cancer development in the oral cavity, whether in a clinically definable precursor lesion or in clinically normal oral mucosa. The term OPMD is a relatively new term coined in 2006 because the previous terms, precancerous lesions and conditions, were determined to be unsuitable by a group of experts. This is because the term precancerous denotes the stage prior to development of cancer, but as all such lesions do not develop into cancer, OPMD was considered to be the better term. This slide shows the list of OPMDs that were included in the 2017 WHO Blue Book on Head and Neck Tumors. So, chronic candidiasis is a lesion that has been newly added to the OPMD list. There are two concerns about this list. The first one is the proliferative verrucous leukoplakia. It is not included in this list. Now, compared to erythroleukoplakia and leukoplakia, proliferative leukoplakia has a different presentation as well as it has a higher malignant transformation list. So I wonder why EVL was not included in this list of OPMDs. However, when you read the text in the book, they do mention proliferative verrucous leukoplakia. The second concern is there's a recently described entity known as high-risk HPV-associated epithelial dysplasia. So this lesion has not been included in this list as well. But the reason can be that high-risk HPV-related epithelial dysplasia is a purely histopathological diagnosis. Whereas if you consider the other lesions included under OPMDs, most of these lesions are really clinical diagnosis. So that may be one reason why high-risk HPV-related epithelial dysplasia was not included in this list of OPMDs. Now, this picture shows a red and white mixed lesion in a patient presenting with stained teeth characteristic of beetle quid use. So the most likely clinical diagnosis is erythroleukoplakia. Now, when we consider this type of lesions, different severities, if you look at the lesion under the microscope, all over the place, you will not see the same grade of dysplasia. Because of that, and also considering the size of the lesion, it would be better if you can take more than one biopsy to include red areas which would show more severe dysplastic features. Let's consider the background information of oral epithelial dysplasia. So, oral epithelial dysplasia is defined as a spectrum of cytological and architectural epithelial changes caused by accumulation of genetic changes associated with an increased risk of progression to squamous cell carcinoma. The cytological changes are mainly observed in individual cells, while architectural changes means the overall change in the epithelium. Now let's consider the causes of epithelial dysplasia. It is important to remember that oral epithelial dysplasia is a purely histopathological diagnosis that is rendered for lesions considered as oral potentially malignant disorders. So, the causes of oral epithelial dysplasia need to be correlated with the clinical presentations. And also, it is also important to remember that these same causes can produce clinical lesions without epithelial dysplasia as well. So, tobacco use in the form of betel quid, chewing or smoking can produce lesions like leukoplakia, erythroleukoplakia, and erythroplakia. Canal use has been attributed for the development of oral submucous fibrosis. Alcohol together with tobacco has a synergistic effect and it can produce leukoplakia as well as erythroleukoplakia. Candida is responsible for the development of chronic candida lesions, while UV light has been attributed to the development of angular cheilitis. Regarding immunologically mediated diseases like lichen planus and DLE, there's actually no data related to the presence of epithelial dysplasia in these types of lesions. Regarding genetic alterations, an entity known as dyskeratosis congenita has a precancerous stage, but other genetic disorders such as xeroderma pigmentosa, epidermolysis bullosa, the dystrophic form, so these may not have a precancerous stage. Now let's consider the diagnostic features of oral epithelial dysplasia. According to the most recent classification, oral epithelial dysplasia is diagnosed based on 8 cytological changes and 8 architectural changes. If we look at some of these features in detail, increased nuclear cytoplasmic ratio means with abnormal proliferation associated with dysplasia, the nucleus enlarges. When the nucleus enlarges, the cytoplasm, the volume of cytoplasm will get reduced. So it will give rise to an increase in nuclear cytoplasmic ratio. Regarding atypical or abnormal mitotic figures, in normal cell division, a single cell is divided into 2 cells. But in dysplasia, a single cell may divide into 3 cells, 4 cells, or even multiple cells. If you look at the picture here, so you can see a tripolar mitosis which will give rise to 3 cells, and a quadrupolar mitosis that will give rise to 4 cells. Regarding irregular epithelial stratification, now if you look at the normal epithelium, you can clearly identify the different epithelial cell layers. Stratum basale will have a columnar shaped cells. Stratum spinosum has polyhedral shaped cells, whereas the stratum corneum will have flattened spindle shaped cells. In irregular epithelial stratification that is observed in dysplasia, you do not see the typical layers that you would see in the normal epithelium. In addition, premature single cell keratinization means dyskeratosis. If you look at this picture, what are the histopathological features that you see here? First of all, if we consider the cytological features, you can see nuclear and cellular pleomorphism, even abnormally shaped and as well as size cells and nuclei. You can see loss of polarity of the basal cells. You can also see enlarged drop-shaped rectis. So there are a lot of dysplastic features that we can identify in this section. Now, it is not sufficient only to look at the dysplastic features. It is important to grade the lesions as well. For the first time, WHO 2000 classification introduces 2 dysplasia gradings. WHO dysplasia grading has 3 categories. These are divided or classified based on the level in the epithelium to which the dysplastic features extend. So if the dysplastic features extend only up to the lower 1/3 of the epithelium, it is considered as mild epithelial dysplasia. If the dysplastic features extend up to 2/3 of the epithelium, it is known as moderate epithelial dysplasia. If the dysplastic features extend to the top 1/3 of the epithelium, it is known as severe epithelial dysplasia. Regarding the binary system, there are only 2 grades, low-grade dysplasia and high-grade dysplasia. So, if we have to classify high-grade dysplasia, you have to see either 4 architectural features and 5 cytological features, or 4 architectural features and 4 cytological features in the tissue section to call it a high-grade dysplasia. But again, I have one concern here. Both of these researches have been conducted before the 2017 classification was published. So the dysplasia grading that they have used is the 2005 epithelial dysplasia grading system. In that grading system, instead of 8 cytological features and 8 architectural features, 2005 grading had 9 cytological features and 7 architectural features. So it is concerning whether we can apply these findings to the present grading as well. But anyway, in our department, when we look at leukoplakias with dysplasia, we use both WHO grading as well as we give a WHO grading as well as a binary system grading. So at present, we use the 4 architectural and 4 cytological changes as the cutoff point to identify high-grade dysplasia. If we look at these pictures, the second picture shows, this one, shows dysplastic features only extending up to the lower 1/3 of the epithelium. So according to the WHO classification, it is mild dysplasia. If we apply this to the binary grading, this will come out as low risk dysplasia. On the other hand, if we look at this trend, here you can see that the dysplastic features are extending up to about 2/3 of the epithelium. So according to the WHO classification, this is moderate epithelial dysplasia. Here you can see dysplastic features even in the top cell layers. This can be diagnosed as severe epithelial dysplasia. Majority of the lesions diagnosed as severe epithelial dysplasia fall into the high risk dysplasia category according to the binary grade. What is the significance of oral epithelial dysplasia grading? It is important for the management. Depending on the grading, we can identify the lesions that require treatment. It can be surgical or non-surgical treatment. And also, depending on the grading, we can identify the lesions that do not require any surgical or non-surgical treatment. And also, dysplasia grading is important to predict the outcome of the lesion or to predict the behavior. Dysplasia grading is one of the important factors that can be used to predict the malignant transformation risk. So this is a small study that we did in our department, and the aim was to identify the factors that could predict malignant transformation in oral leukoplakia. So according to the results, dysplasia grading was useful in predicting malignant transformation with severe epithelial dysplastic lesions showing higher malignant transformation rate. So if you have a patient with a diagnosis of severe epithelial dysplasia, definitive management is required because otherwise those type of lesions have a higher risk of changing into squamous cell carcinoma. So what are the problems associated with oral epithelial dysplasia grading when we use it for the management? First of all, if we consider the inherent problems associated with the WHO dysplasia grading, now regarding the management, there's no clear guideline for the management of moderate epithelial dysplasia. This is because now if you consider a lesion that has mild epithelial dysplasia only, you can just go for wait and watch policy. Just follow up and habit intervention is adequate. But if you have a patient with a lesion that has been diagnosed as severe epithelial dysplasia, according to the WHO grading, you can surgically excise that patient. But regarding moderate epithelial dysplasia, there's no clear guideline. So that is one problem. But if you consider the binary grading, there are only two categories. So if you get a diagnosis as high-risk dysplasia, then those require definitive treatment, be surgical or non-surgical. Whereas if you get a diagnosis saying it's low-risk dysplasia, just follow up and habit intervention is adequate. The second problem that is associated with the WHO dysplasia grading is the inter and intra-examiner variability. So both can be very high when we use WHO dysplasia grading. In addition, with reference to the prognostic assessment, there's low sensitivity when predicting the lesions that undergo malignant transformation when compared with the binary grading. So they say that binary grading is better to predict prognosis compared to the WHO grade. So again, we did a small study to evaluate the inter-examiner variability in diagnosing oral epithelial dysplasia using conventional WHO grade. According to the results, we can see that all the oral pathologists that have been trained at one center shows good or satisfactory agreement with reference to the different grades of dysplasia diagnosis. This is assessed using kappa values, and the kappa values ranging from 0.5 to 0.4 was obtained among the oral pathologists. However, though it is satisfactory, there's no 100% agreement among these diagnoses. So there's a little bit more work to do to further reduce the inter-examiner variability in our department with reference to the diagnosis of oral epithelial dysplasia. Regarding the last examiner, there's a very high inter-examiner variability. So the message that I want to give you is that if you have a patient with a OPMD, like leukoplakia, and if you are planning to take a biopsy, it is better to get this biopsy read by a person who has been trained to read oral biopsies. Sumudu, shall we move on to the poll now?
Yes, madam.
First one.
Yeah, I'm launching the poll, madam. It's on the screen.
Can we have the results, please?
Yes, madam. Results are on the screen, madam.
Yes, it is correct because number 3 means it's a red area. So that is the area where you would most likely to identify more severe dysplastic features. Shall we move on to the second one, please?
Yes. The poll is on the screen, madam.
Can we have the results, please?
Yes, ma'am. So the results are on the screen.
Yeah. So the correct answer is the first one, because with the binary grading, because there are only two categories, low risk and high risk dysplasia, surgeons are able to accurately identify all the lesions that require definitive surgical management. Shall we move on to the third one, please, Sumudu?
Yes, ma'am.
First look at the picture. Can we have the results, please?
Yes. Results are on the screen.
Okay, it's a difficult one. The correct answer is severe epithelial dysplasia. I will talk about this lesion later. So let's move on to the fourth one, please. Just consider this lesion for the fourth quiz as well. Can we see the
Yeah, fourth poll on the screen.
Can we have the results, please?
Yes, ma'am. The results are on the screen.
Okay. Right. Thank you, Sumudu.
Come, madam.
Okay. So actually, now when you look at this picture, I gave this picture mainly because look at the B, photomicrograph classified as B, and in that you can see very large bulbous rectus. Right? But the thing is, other than the bulbous rectus and dyskeratosis, that is these cells seen in picture C, you don't see any other architectural disturbances. But actually, this is a severely dysplastic lesion. So I really wanted to give you this slide to show you that although on some aspects the binary grading is better than WHO grading, it is not 100% accurate when it comes to diagnose certain types of dysplastic lesions. Because if you look at this picture, there are only two architectural changes. So according to the binary grading, this should be diagnosed as a low-risk dysplasia. But actually, if you look at the first picture, you can see dyskeratosis, that is the architectural disturbance, extending even up to the top layers. So according to the WHO grading, this is severe epithelial dysplasia. And according to the binary grading, this should have been diagnosed as high-risk dysplasia. But if we really apply the binary grading, we can only find 2 architectural features only. So this is an instance where the binary grading fails to give the accurate oral epithelial dysplasia grading. Now there's another challenge when we diagnose oral epithelial dysplastic lesions. That is because there are certain lesions, reactive lesions, that can be misdiagnosed as oral epithelial dysplasia. One example is the regeneration atypia that is present at the edges of ulcers. Now, if you look at the picture, this is the ulcer. So you don't see the epithelium. At the edge of the ulcer, you can see a fragment of epithelium. And here, if you look at these epithelial features, we see increased mitosis, even nuclear hyperchromatism, things like that. That is mainly because during the healing phase of the ulcer, the epithelium has to proliferate and then it has to bridge the gap that is created by the ulcer. So although under the microscope this looks like dysplasia, it is not true dysplasia. This is known as regeneration atypia. So sometimes regeneration atypia can be mistakenly diagnosed as oral epithelial dysplasia. And also there are other lesions created by nutritional deficiencies and also changes induced by radiation or chemotherapy may show features that can mimic dysplasia. So if you look at this picture, under the microscope, you can see nuclear hyperchromatism. There's a lot of atypical features, maybe even extending up to 2/3 of the epithelium. But actually, these changes have occurred due to the results of chemotherapy. These are chemotherapy-induced change. And if you look at the second picture, you can see some abnormal nuclei. So this type of change occurs when the patient has certain nutritional deficiency. So if the clinicians are aware that this type of things are going on in the patients from whom you have taken biopsies, it is important to mention such information in the biopsy request forms. So if that information is given, we can avoid misdiagnosis. I think oral submucous fibrosis was discussed in a previous webinar. So what I wanted to tell you regarding oral submucous fibrosis is that it is a disease characterized by proliferation of fibroblasts. And if you look at the histopathological features, you can see the corium, and the corium is replaced by fibrous tissue, dense fibrous tissue. At this stage, if you look at the surface epithelium, you generally see an atrophic surface epithelium. And when you look at this fibrosis, sometimes in advanced cases, you may see the fibrosis extending into the muscles, producing muscle atrophy. Now, that is the typical presentation of oral submucous fibrosis. But with time, the patients, if they continue the habits, the patients may develop what is known as early budding retitis. So if you look at this picture, originally you would see a very thin, flat epithelium, but with time you see the development of this small early budding retitis. So if you look at the features, For this type of lesion, we can only give a diagnosis of maximum mild epithelial dysplasia. Even mild epithelial dysplasia we can't give. We can call it focal mild epithelial dysplasia. Now, this finding is important because presence of early budding rectus means the epithelium has started to proliferate. So, it's a significant finding. But if we diagnose this lesion as mild epithelial dysplasia, then what is the management? Management is just follow-up only. So, there's a problem in the application of the conventional oral epithelial dysplasia grading in oral submucous fibrosis. And also, there's another finding that we may see in oral submucous fibrosis patients who are undergoing malignant transformation. They may present with verrucous growth, something similar to this lesion. Why do these patients present with verrucous growths? Mainly because the corium exhibits dense fibrosis. So, because of the dense fibrosis, it will prevent the invasion that is necessary for the development of squamous cell carcinoma. So, histopathologically also, if you look at the histopathological appearance of the verrucous growths, they will show only minimum amount of atypia. However, these lesions should be managed as high-risk lesions with excision. If you do that, the chance of developing distant metastasis or regional metastasis can be prevented, and also the patient's survival will be better. As I said before, HPV-associated epithelial dysplasia is a relatively new entity that has been introduced. So here the clinical presentation-wise, you will see the lesions will show a predilection to the flow of the mouth and the tongue. And these lesions are also more common in males, similar to leukoplakia. Histopathologically, you may see what is known as hyperkeratosis. Here you can see hyperkeratosis. Then also you may see certain cells. We call this karyorectic cells. And another term that we can use is mitocyte bodies. So mitocyte bodies are a type of cells that you see in a different type of lesion known as disease. So these mitocyte bodies actually resembles mitotic figures. So we are not aware of mitocyte bodies. Sometimes these oral high-risk HPV-related epithelial dysplasias can be given a very high grade of dysplasia. In addition to the karyorectic cells, these HPV-related epithelial dysplasia will show another type of cell, and these, according to this literature or the paper, they call this apoptic cells. But if you consider high-risk HPV, it has a gene that can inhibit the action of p53. So when the action of p53 is inhibited, that means apoptosis may not take place. So though these cells have been described as apoptosis, maybe in another paper I saw that it is better to describe these cells as dyskeratotic cells, considering the pathogenesis associated with the human papilloma virus. If we want to diagnose the presence of human papilloma virus, you can do two things. You can use P16, which is a surrogate marker to identify human papillomavirus, or otherwise we can do in situ hybridization to identify the human papilloma virus. So if we use P16, they say that you have to see more than 75% of the epithelium should be positive and to diagnose the lesion or to consider the lesion as exhibiting P16. Another lesion that you need to know is proliferative verrucous leukoplakia, mainly because it is the lesion with the highest malignant transformation risk. And also considering the presentation wise, in contrast to leukoplakia, which is more common in males, PVL is more common in females, and also it is more common in elderly females. And generally leukoplakia present as a single lesion, whereas PVL present as multifocal lesions that can involve, for example, if you look at this area, gingiva, then also it is extending to the lip. And if you look at the other side, maybe it is extending to the floor of the mouth as well. So generally PVL presents as a very large lesion. And histopathologically also, we say that PVL is a retrospective diagnosis mainly because generally, in order to diagnose PVL, we have to have series of biopsies. So the lesion will change from a hyperkeratotic patch to show varying degrees of dysplasia. Then it will present as a verrucous lesion, and thereafter it can develop into a verrucous carcinoma or a squamous cell carcinoma. Again, in proliferative verrucous leukoplakia, if you look at the verrucous lesion, the lesion generally shows minimum atypia, but even though it is showing minimum atypia, should be managed as a high-risk lesion. So the lesions with verrucous morphology, even in the absence of high rate of cellular atypia, should be managed as a high-risk lesion. Regarding lichen planus, of course, it has a very, very low malignant transformation rate, and the malignant transformation rate is mainly associated with malignant transformation is mainly seen in erosive lichen planus. Now, if we consider the histopathological appearance, there's one important fact to remember, and that is in lichen planus, you can see this band-like lymphocytic infiltrate which extend into the epithelium producing basal cell destruction. So, oral epithelial dysplastic lesions can also present with a dense lymphocytic infiltrate, and this can lead to a misdiagnosis of OED as oral lichen planus or vice versa. So actually, no evidence exists to correlate the grade of oral epithelial dysplasia with malignant transformation in oral lichen planus. So the next lesion is chronic candidiasis. Now, with reference to candidal infections, there are several subtypes of candidal infections. Generally, things like pseudomembranous candidiasis or acute atrophic candidiasis or denture stomatitis does not change into malignancies. But the important lesion with reference to malignant transformation is chronic hyperplastic candidiasis. Now, with reference to chronic hyperplastic candidiasis, how do you diagnose it? If you take an incisional biopsy, in an incisional biopsy, In a H&E stain section, you will see this elongated rectus, and also you may see these neutrophil microabscesses on the surface. So those two features are indicative of candidal infection. So if you find that type of features in an incisional biopsy, it is better to do a GPA stain to see whether there is candidal hyphae invading into the epithelium. In chronic hyperplastic candidiasis, you will see this magenta colored hyphae invading into the epithelium in a perpendicular direction. So, if you see elongated rectus and neutrophil microabscesses, you can request a special stain like the DPS stain to identify candida. And if you see this magenta colored hyphae, then you can diagnose the lesion as chronic hyperplastic candidiasis. Now, the candida itself can produce certain carcinogenic material. One example is nitrosamines. So, these carcinogenic material can show certain dysplastic features in the first biopsy itself. But in a chronic hyperplastic candidiasis lesion, even if you see dysplastic features in the first biopsy, we generally don't grade the dysplasia. This is mainly because after treatment, these dysplastic features can disappear sometimes. In the second biopsy, after treatment, if the dysplastic features don't disappear, then of course you can treat the lesion considering the grade of dysplasia. If you get a severe dysplasia grade, then you have to excise the lesion, whereas if you just get mild dysplasia after the treatment, then you can follow up the lesion. There's another problem, and that is sometimes the leukoplakia lesions can have candida superinfection. And also, how do you differentiate leukoplakias with candida superinfection from chronic hyperplastic candidiasis? It is a difficult question to answer. So you can consider things like the habit history. So if there are relevant habits, maybe it is leukoplakia, not chronic hyperplastic candidiasis, but that is not a definite finding. And finally, if we consider the dysplasia, how does dysplasia influence the oral cancer management? The only way in which the dysplasia influence oral cancer management is that now if you excise the oral cancer lesion, we generally look at the margins to see if the tumor is clear or if there's tumor very close to the margin. At the same time, we can see if there's dysplasia extending into the excision margin. Now, according to the literature, they say that moderate and severe epithelial dysplasia present at margins may affect prognosis, but also the presence of dysplasia at excision margins contradicts the use of radiotherapy, but it does not significantly influence the loco-regional recurrence. This is mainly because most of the time, if you have an oral cancer patient and if you get a report saying that severe dysplasia is extending into certain margins, most of the time you will re-excise the lesion. So that is why we can't find any evidence in the literature to show that presence of severe epithelial dysplasia to contribute to local differences. There's another point that I want to make. Now, we were talking about the dysplasia that we see in oral potentially malignant lesions. But it is not completely clear whether the dysplasia that is present at the resection margins are of the same caliber as the dysplastic features appearing in oral potentially malignant disorders. So that is the area where you can do some research. Finally, the take-home messages are: oral epithelial dysplasia grading is extremely important to manage and predict prognosis of leukoplakia and erythroplakia. But its significance in the management of, sometimes management, it can be used for management, but mainly for the prediction of prognosis of other oral potentially malignant disorders is controversial. And also, as different areas of leukoplakia may show different levels or degrees of dysplasia, careful selection of biopsy sites is extremely important for patient management. And thirdly, clinicians should be aware of lesions that can mimic oral epithelial dysplasia and mention those if present at the time of sending biopsies in order to avoid misdiagnosis of non-dysplastic lesions as dysplasia. Thank you.
Thank you, madam. Now we will be moving on to the questions and answer session. I'll take the first question. The first question is from an anonymous attendee. Does erythroleukoplakia and speckled leukoplakia are same?
Yes, speckled leukoplakia is the older term for erythroleukoplakia.
Okay, thank you, madam.
Okay, madam, the second question is from Dr. Rasika Ekanayake. Isn't epithelial dysplasia associated with high-risk HPV presented clinically as leukoplakia? In that case, can't we consider it as a leukoplakia? Or else, madam, there are three parts in the question. Shall I read everything together? Yeah. In that case, can't we consider it as a leukoplakia, or else is it categorized as a separate entity?
Yeah, I think like the WHO doesn't mention anything about HPV-related epithelial dysplasia. And also I could only find about 2 papers in the literature. So maybe it is too early to consider HPV-related leukoplakia with the traditional leukoplakia.
Okay, thank you, madam.
The next question is from an anonymous attendee. Does betel leaf itself contain carcinogenic potential?
As far as I know, no.
Okay, thank you, madam.
Madam, this question is from Dr. Chandira. Madam, is it a must that the same oral pathologist assess the grade of dysplasia of 2 biopsies of the same lesion taken from the same patient, taken 2 different times?
Not really. There's no must like that.
Thank you, madam.
The next question is from an anonymous attendee. In oral cancer histopathology reports reported by general pathologists, they do not report the in great detail like oral pathologists, like invasion front, etc. Why is that? No any offense offered any party. It's within the brackets, madam.
It is very difficult to answer because I am not a general pathologist. So I think I will skip that.
Okay, madam.
Another question from Dr. Rasika Ekanayake. How do you differentiate radio or chemotherapy-induced dysplasia-like features from true dysplasia?
Again, very difficult. That is why I said that it is important to get the correct history.
Okay. Thank you very much.
Maybe under the microscope, it is almost, under light microscope, it is almost impossible.
Okay. Thank you.
Dr. Chandira Gunasena has raised this question. Madam, staining with P16 in identifying HPV, can previous slide used earlier for histopathological diagnosis be used?
No, but if you have the wax block, you can take a new section and stain it with P16.
Okay, thank you, madam.
Thank you. Okay, ma'am. We have a question from anonymous attendee. How we will differentiate leukoplakia with supraaded candidal infection from candidal leukoplakia histopathologically?
Yeah, that is very difficult. So that is why I think in the initial biopsy, it may be almost impossible. But like in the second biopsy, maybe, if so in the second biopsy also it is impossible. I'm not very sure about the answer.
Okay. Thank you, madam.
Other than correlating it with the habit history and things like that, it is difficult to differentiate those two. That was what was mentioned in the presentation as well.
Okay, thank you, madam. Dr. Lydia has raised this question. Excellent conference, doctor. When there are changes in the epithelium associated with candida, when removing the infection, does the epithelium recovers its morphology?
Yes, sometimes the epithelium can recover its morphology. So sometimes it won't.
Okay, thank you, madam.
We can't really say which lesion will recover its normal morphology and which won't. Really. You have to test and see.
Okay, thank you, madam.
Thank you. And this question is from Dr. Alejandro Gonzalez. So first of all, he congratulates you for the excellent presentation. And would you recommend that all lesions with dysplasia undergo pass for candida staining, madam?
Well, in our department, if we find any histopathological features suggestive of candida superinfection like neutrophil microabscesses, we do a DPA stain. Otherwise, we don't really stain the lesions to look for candida.
Thank you, madam.
Madam, Dr. Mohammed Nishan has raised this question, actually two questions. Excellent presentation, ma'am. One doubt. In some of my cases encountered with oral lichenoid dysplasia with grading mild, moderate, and severe, in which of these cases would you advise wait and watch, and which ones excision? Also, can we start corticosteroids taking into consideration if it is oral lichen planus?
Okay. Firstly, I did not touch upon lichenoid dysplasia mainly because it's a relatively controversial entity, because according to some papers, they say that you can't diagnose lichen planus if you see dysplasia. Right? But if you really read the literature on lichenoid dysplasia, they say that in lichenoid dysplasia, you should see typical features supportive of lichen planus with two dysplastic features. Right? So if you see typical features supportive of lichen planus plus another two dysplastic features, then you can give the diagnosis of lichenoid dysplasia. So if it is only, let's say, very low amount of dysplasia, like mild dysplasia, then of course you can use the traditional treatment methods that you would use for lichen planus. But anyway, it is essential to carefully follow up these patients.
Thank you very much, ma'am. And this question is from Dr. Amita, and that is on how do nutritional deficiencies contribute to epithelial dysplasia?
It actually does not contribute to epithelial dysplasia per se, but due to certain nutritional deficiencies, you may see certain nuclear changes that can be mistaken for epithelial dysplasia.
Is there effect on nutritional deficiencies for malignant translation of epithelial dysplasia?
Yes. Actually, if you consider Plummer-Vinson syndrome, things like that.
Yes.
But the thing is, again, I did not include it in this presentation mainly because I could not find any relationship with the dysplasia and Plummer-Vinson syndrome. Yes, in Plummer-Vinson syndrome, it gives rise to malignancies, but there was no relationship with dysplasia and Plummer-Vinson syndrome. That is why I did not include it in the presentation as well.
Thank you, ma'am.
Dr. Mamuti has raised this question, madam. Do you recommend treating all homogeneous leukoplakia with anti-candidal medication?
If a clinician can answer it, I would be very grateful.
Yeah, I think we have Professor Jayasooriya. Can I have him in the discussion, madam?
Yes, sure.
Yeah.
In the meantime, shall I move on with the other questions?
Yeah, please,
Yes.
please.
The next question is from an anonymous attendee. Can Madam highlight regarding toluidine blue test to determine dysplastic cells?
Okay, I can mainly discuss maybe the pathological basis. When you apply toluidine blue dye, if the cells are proliferating, then the nuclei will take up the dye and then it will give a bluish color. So those are the areas where you have to take biopsies because those are the areas where you would see either severe grades of dysplasia or even carcinoma.
Okay, thank you, madam.
I think Professor Jayasooriya is offline at the moment, madam.
Right.
I can share a brief answer for this.
Sure.
Yeah,
Yes,
actually, my direct answer would be no. I think now if any lesion is not clinically proven to be having candidal candida, and if we prescribe a candidal medication, that would be a over medication, actually unnecessary prescription of medication. So once it is proven, prescribing candida would be a good option than rather prescribing everything. But with improvement of the clinical experience and with the time, some clinicians develop the ability to predict candida in certain lesions. With the looks and with certain other features and assessing the general medical health of the patient. In that case, sometimes experienced clinicians use that.
Okay, thank you, Dr. Sumudu. Madam, the next question is from an anonymous attendee. Madam, can we take biopsy of leukoplakia after staining with toluidine blue?
Yeah, you can do a biopsy after staining it with toluidine.
Okay, thank you, madam.
Another question from Dr. Varsha. Does cancer stem cell have any role to play in development of oral squamous cell carcinoma from dysplasia? May I repeat the question, ma'am?
I understood the question.
Yeah.
So, okay. So actually, we did some basic research related to cancer stem cell markers. And one of the stem cell markers that I used was aldehyde dehydrogenase. So there we found that there's a slight association with aldehyde dehydrogenase expression with the presence of regional metastasis, and also there's a relationship with the presence of improved survival. So those are the findings that I had in my research. Actually, I have not applied cancer stem cell markers, either aldehyde dehydrogenase or any other marker, on epithelial dysplasia. So it's very difficult to comment on the effect of stem cells on epithelial dysplasia.
Okay, thank you, ma'am.
Another anonymous attendee has raised this question. Ma'am, would you recommend vital staining for proliferative verrucous leukoplakia?
Again, Sumudu, is it possible to answer?
Yeah, actually, madam, proliferative verrucous leukoplakia is a retrospective diagnosis. Now, we can use vital staining in cases of obtaining biopsies. So, of course, sure, we can use.
Thank you.
Okay.
The next question from another anonymous attendee. Role of HPV in epithelial dysplasia transforming into malignancy. What is the role of HPV in epithelial dysplasia transforming into malignancy?
Okay, so like in that same study that I mentioned, with follow-up, they found that some of the lesions that had high-risk epithelial human papilloma virus. Sorry, Udari, what was the question? Role of?
What is the role of HPV in epithelial dysplasia?
Right, okay. So in the study that I mentioned, they mentioned that some of the lesions that showed high risk human papilloma virus related HPV or epithelial dysplasia did transform into malignancy. But if you consider the role of HPV in the malignant transformation, I can say two things. Like HPV has two genes. One gene is E5 gene. So E5 gene will inhibit the action of P53. P53 is important to induce apoptosis. So when the apoptosis is not induced, that means even the cells that contain DNA damage or anything like that can't be removed, and this can give rise to malignancy. The second point is the human papilloma virus also has another gene known as E7, and the E7 gene can stimulate the retinoblastoma gene or that pathway and stimulate the proliferative activity. So by stimulating the proliferative activity or uncontrolled proliferation of cells also, the lesion may change into a malignancy.
Thank you, ma'am.
Thank you, ma'am. So this question is from Dr. Radhika. Excellent and clear presentation, madam. Just want to know the treatment regime you follow for leukoplakia.
Oh, okay. So we have national guidelines.
I think, madam, we can answer that question with the
guidelines. Yes.
Guidelines, yes. I think we have a question, similar question over email as well, asking whether we have developed the guidelines. Yes, we have guidelines developed involving many institutions, including Faculty of Dental Sciences and institutions from Ministry of Health. Shall I share the guidelines so you can download it? Anybody can download it over internet from National Cancer Control Program Sri Lanka website. I'll share the guideline.
Thank you. Madam, Dr. Tashi has raised this question. In the management of OSMF, I had a case whereby fibrosis and mouth opening was improved with placental injection, but how can the burning sensation of buccal mucosa can be managed?
Okay, again, I'm not a clinician, but maybe if the patient has any nutritional deficiencies, if you correct the nutritional deficiencies, maybe the burning sensation can be reduced. But maybe Sumudu can add something to it as
Madam,
well.
this is again a controversial area. This is again a controversial area, and there are lots of things to study on this aspect. And what really Dr. Tashi asking, there's no particular answer for that.
Thank you.
Yeah, there are a few case reports and case series, some studies coming up, but for this particular answer, I think I haven't come across something.
Okay, thank you. There's another question.
From now, the cancer guide, OPMD guidelines are on the screen, madam. Okay, right. Dari, can we have the next question, please?
Okay. Another anonymous attendee has raised this question. Madam, excellent presentation. Is it correct that doing biopsy of OSMF leads to oral squamous cell carcinoma? Doing biopsy of OSMF is recommended or not?
Okay, one theory is that now, because oral submucous fibrosis is an entity where fibrosis occurs, and if you do a biopsy, it can again give rise to more fibrosis. So whenever possible, you can avoid taking biopsies, and if possible, you can diagnose oral submucous fibrosis clinically. But if there are certain leukoplakia patches or lesions suspicious of malignancy, then you have to take biopsies from oral submucous fibrosis patients.
Okay,
Thank you, madam. This question is from Dr. Zuneira. Which stain is better for candidiasis, PAS or GMS?
Okay, so in our department we use DPS, but you can use the Brocut Gomory method as well. The thing about that method is that you get a lot of silver deposits and it is somewhat difficult to do. But the DPS stain is more easy, so the interpretation is also easy.
Thank you, madam.
Thank you, madam.
Another anonymous attendee has raised this question. In OSMF, patient treated by corticosteroid, how long we can give steroid when progress is very low?
Again, Sumudu, can you answer that?
Yeah. Actually, madam, in our department, what we use is corticosteroid injections. The drug of choice is methylprednisolone. So the regime we use is 20 milligrams on each buccal mucosa out towards the fibrous bands every monthly for 5 months. So that is the regime we use. And what we do is we continue that for 5 months and assess the progress. So if patient is not responding, so we wait for some time. It depends on the decisions of multiple clinicians, the multiple consultants involving. And there are situations where we decide to go for a second course of corticosteroids. Failing that, we sometimes, now if the condition severely affects the patient functionally, we go for the surgical management. Surgical management is in the sense removal of fibrous bands and reconstruction the area with a suitable reconstructive option.
Yeah, thank you. Madam, Dr. Mamuti has raised a question. Could you elaborate a bit more on retrospective diagnosis of PVL?
Okay, so sometimes a patient may present with squamous cell carcinoma or a verrucous carcinoma. But when you look at the patient's history, you may see a lot of biopsies have been taken, and there are a lot of previous biopsy reports. So if you go through these biopsy reports, you will see that initially the lesion will present as a white hyperkeratotic patch. With time, it will show certain dysplastic features. So again, after some time, the patients may develop a verrucous lesion, and if you don't completely excise it, with time it can give rise to verrucous carcinoma or squamous cell carcinoma. So we can go through all of those biopsies, and if we see these serial changes at the time that the squamous cell carcinoma is diagnosed, you can say that this patient developed the squamous cell carcinoma from proliferative verrucous leukopenia. That is why we call it a retrospective diagnosis. So throughout time, the lesions will show series of changes from white hyperkeratotic patch to verrucous appearing lesion.
Thank you, Madam.
Thank you, madam. Another question from anonymous attendee. Great presentation, ma'am. How much is the probability of an OSMF to present with oral squamous cell carcinoma? The infamous,
Yes, sorry.
the infamous OSMF oral squamous cell carcinoma entity.
Okay, if you are asking the malignant transformation rate, literature says that it can vary from maybe
8%.
7% to 13%.
Okay. Okay, madam. I think now his question intends on that, or I wonder whether he's expecting the presentation at different grades, grade 1, 2, 3, 4, 5.
Right,
Yes.
depending on the histopathology.
Yes, histopathology and the clinical presentation, maybe.
So, Sumudu, can you?
Yeah, I don't think there's a clear-cut study to say the percentages, madam. So at this moment, I don't think I'm not knowledgeable enough to answer this question.
Okay, thank you. Moving on to the next question by Dr. Swati Raman. Madam, can you explain the concept of precancer?
Okay, so now when we consider the terms that were used before the introduction of oral potentially malignant disorders, two terms were used, precancerous lesion and precancerous condition. So if we consider the term precancerous lesion, that means there's a clinically definable precursor lesion, and on this side you will see the development of a squamous cell cancer. So in other words, in precancerous lesions, the cancer develops at the site where you see the precursor lesion. On the other hand, if you consider the term precancerous condition, there the example would be something like oral submucous fibrosis. There's no clinically visible precursor lesion, but the cancer can develop in an apparently normal mucosa. So it's a generalized state where the cancer can develop at any mucosal site even without a clinically definable lesion.
Okay, thank you, madam.
I think, madam, you shared an elaborative answer for this question at the initial stage of your presentation. So we'll be uploading that presentation to YouTube. Please subscribe for our YouTube channel, so you may be able to enjoy the presentation lengthy.
Okay. Thank you, madam. Now, that remarks the conclusion of this session, and thank you very much, everyone, for staying connected. Hope you all had a fruitful session. Let me once again thank Professor Primali Jayasooriya for her contribution to this session. And also, I would like to thank Dr. Sumudu Medawela, because he was the main person who took the initiative and the person who has been providing the technical support in organizing the entire webinar series. So Dr. Sumudu, thank you very much. Before winding up, there is a kind reminder. This webinar will follow up with an email. Please follow the link to submit your feedback for further improvement. In the meantime, you can get registered to our next webinar on the topic orofacial infection. Thank you for joining. Good night.
Good night.